more effective treatment or just keeping the patient alive to probably give some hope. And of course, I talked about the complications as well. Several
3
cases.
minutes, please.
Yes, there are the several cases at the end. So one case, it is very difficult to see. This is a small liver metastasis of a neuroendocrine tumor in the right lobe of the liver, much larger on the ultrasound just before the treatment. We did a combined treatment of a radiofrequency embolization device, and we did an embolization. This artery is blocked, and the end result was a complete remission of that. There is no lesion there at all. So it can be done. It is really a powerful tool. In larger or multiple lesions like that, this is a huge lesion in the right lobe of the liver. It's here. We do repeated embolization therapy to decrease the size. And in certain terrible situations like here, when the metastatic tumor just invaded the portal vein and the patient developed varicose bleeding because of that, we just went for a portal venous stenting just to do a bridging of the portal vein and bridging the patient to reach the Dotatok therapy. So this is the stent here in this position, and it was really successful, of course, for a time. So it's a palliative treatment. So last two slides. I think we are highly effective. We have very good tools. They are always developing. I think we can include them into our therapeutic protocols. We can combine them in any situations. Very difficult to say when and in which situation. Therefore, we need the team, and we decide together. So we should be included in the endocrine oncologic multidisciplinary team, I think. And the follow-up should be analyzed together as well, because sometimes it's difficult and to decide where to go after some controls. Availability, cost, subjective measures are always a problem and always an issue. Thank you for your attention.
Thank you very much. Are there any questions? No, thank you very much. And let's move to the next topic, the role of immunotherapy and Merkel's carcinoma. I will ask Dr. Bajtseva from Children's Oncology Clinic in University Hospital Brno.
Good evening. Thank you for the invitation and to take part in this beautiful meeting, and welcome you all in Brno. I'd like to tell you something about probably some controversies and means role of immunotherapy for NETs. As you already know, you are working in the field of oncology. You know that during the last years, since 2011, when ipilimumab was the first checkpoint inhibitor approved in FDA, there was a boom of the immunotherapy in oncology. And of course, it's shown this year on the Nobel Prize, when the Nobel Prize for medicine received the Professor Allison from USA and Professor Honio from the Japan, and it is because of their discovery of the cancer therapy by inhibition of negative immune regulation. Modern immunotherapy, or who are working in the field of the medicine or medical oncology, you know that more than 2 decades, 3 decades, you know that if there is something new, it is the boom. Everything we will treat, or everybody we will treat with this new method, as we said, who is not running fast on the street. So a couple of years before also the immunotherapy, there was big enthusiasm, and finally we found something which will be working against the cancer. But now we know that immunotherapy is really very promising treatment modality in oncology, but it is not for everyone and for every type of the tumor. We can see the therapeutic effect is really different. It depends on the type of the tumor. Some tumors responding more than 80%, some tumors only 5% or less. Here you can see spectrum of the malignant diseases where the PD-L1 or PD-1 blockade has been used in the medical oncology in different types of the clinical studies. So, as I said, immunotherapy is appropriate method, but based on immunological subgroups of the tumor, molecular subgroups, and histologic subgroups. So, I try to explain what is the situation with neuroendocrine tumors in this field of medical oncology. Because the immunotherapy is not working for every type of the tumor first, and the current research is focused on to find some predictive factors which are able to predict if this tumor will respond yes or not. And now we can recognize three main groups of the predictive biomarkers. First, in the so-called tumor factors, the tumor's antigens, especially mutation load or mutation burden of the tumor, or tumors with the high genetic instability, high microsatellite instability, tumor microenvironment, very discussing biomarkers, type of the tumor environment, type of the tumor infiltration lymphocytes, and especially PD-1, PD-L1 expression, which from all these biomarkers, only this one was approved by FDA until now. But again, it is even the tumors which has negative PD-L1 expression could respond to the immunotherapy. And the last one is the host environment and factors of the host of the patients. So step by step, what is the situation is in the neuroendocrine tumors. First, tumor burden. You know that the tumor escape from the immune surveillance is the process of immunoaddition. The tumor has the systems that help him to escape from the immune surveillance. And the tumor with high genetic instability leads to the new tumor-specific antigens which are able to be recognized by the immune system. And in neuroendocrine tumors, the native and treatment-induced antigens releases offers the potential target for immunotherapy. This is the chronically known picture, showed as genetic tumor instability or mutation load in different types of the tumors. And here you can see that the neuroendocrine tumors, unfortunately, are the tumors with low mutation burden. So there is not low mutation, especially for well-differentiated neuroendocrine tumors. As you can see here, is usually low, about 3% of the NETs, and means high-grade NETs or neuroendocrine carcinomas have more than 17% mutations or 17 mutations per 1 megabase. When we are talking about high mutation rate, is usually more than 20 per megabase. So this is the limitation factor for effectiveness of the immunotherapy in NETs. Here you can see the different type of the NETs, because as you know, and it was said today, we hear today, that the neuroendocrine tumors are very different and heterogeneous group of the tumors on the multiple ways. So here you can see the different significant mutation based on the type of the tumor, poorly differentiated pancreatic or non-pancreatic NETs, and you can see the big differences. Here is typical picture known from about the pancreatic NETs. So again, it depends on the type of the tumor, localization of the tumor, grade of the tumor, and so on, so on, so on. Microsatellite instability in neuroendocrine tumors are usually low. And only there is the special subgroup of the NETs with high microsatellite instability, and it is in old classification MANEC. Now I hear there is MINEN, or sporadic insulinoma. All other NETs usually they have low microsatellite instability. What about the tumor microenvironment? We are talking about the type of the tumor infiltrated lymphocytes. And we can see that lymphocytes is frequently seen in neuroendocrine tumors, but again depends where it is, so localization, what grade, and again the problem is heterogeneity of the nets. Quite frequently there are tumor-associated macrophages. And the third point is PD-L1 expression. Again, it depends if it is in the tumor tissue, means PD-L1 expression, or stroma, on the lymphocytes, PD-1 expression. Different according, again, the same what I said before. Based on these particles or parameters, we can recognize the three types of the tumor microenvironment: pro-inflammatory or inflamed cancer, or non-inflamed cancer. And this non-inflamed cancer could be tumor excluded or desert, or immune excluded and immune desert tumors. Here you can see the definition. What does it mean? And usually the tumors responding well to the immunotherapy are inflamed cancer. So what is the situation in the NETs? Here is the publication or article published in 2016 describing expression in lung NETs, and again you can see the big difference based on the well differentiated small cell or large cell NEC. You can see that there is really very important or different expression of positivity. Here it is the actually published article from this year, when there is PD-L1 expression in lung nets. There is again the 70 samples of the tumors, and they follow three parameters. First is PD-L1 expression, then CD8, so cytotoxic lymphocytes, and then lymphoid aggregates present. And very important is this part. And based on all these three parameters, the Teng defined 4 cancer subgroups. Depends on the positivity of PDL and tumor infiltrating lymphocytes. Here you can see again the best response to the immunotherapy is in the first group, which is not case usually or for NETs. Here it is published for the first time some studies which are exploring the PD-L1 pathways in NET, and depends on the differentiation, poorly differentiated, mixed population, and well differentiated. So now, because it is very limited information regarding tumor microenvironment in NET. The last group of the predictive factors is host environment. You know that we are all changing within increasing the age. So performance status, comorbidities, metabolic changes, some genetic changes in predisposition syndromes, and epigenetic changes leads to cellular changes when we can observe in the neuroendocrine tumors. Again, it was published in 2016. Now discussed in so many conferences. Microbiota, I don't know, most of or some of you could be gastroenterologists, so you know more than me about the microbiota. It is unknown. The role of microbiota in neuroendocrine tumors is totally wide field. There is no information regarding this. And now I shift from the characterization of NETs to the treatment, as you can see here, and we heard already different types of the treatment using for NETs. So one of these possibilities is immunotherapy, since now it can be used usually as a part of the clinical trials or as a predictive or personalized medicine. So the problem for the immunotherapy is again the microenvironment and PD-L1 expression and all these factors we said, and especially heterogeneity of the tumors, so small number of the patients. But the idea of the immunotherapy for NETs is not quite young, because for the first time described the effect of interferon for NETs, Professor Olberg, and it is long time before. And now I'm sorry, I cannot see the name exactly. Thanks. Castano published very nice paper when they summarized the literature information, 27 studies treated with interferon, as you can see on this live table. So there was objective responses and stabilization and progression, quite good numbers. Of course, for modern era is not enough, but we cannot say based on these reports that interferon do something with neuroendocrine tumor, and is for some cases could be the effective treatment. Again, the article from published in this year, where are the first experiences of using modern checkpoint inhibitors for NETs. Many informations, or the most informations from the NET tumors is neuroendocrine tumors of the lungs. Of course, there are worse, and prognosis is worse, so that's why probably they were indicated for the immunotherapy. You can see here stage 3B or 4 in pre-treated patients, so used as a several line of the treatment. Partial response 60%, stable disease 10%, median progression-free survival 57 weeks. For the cervix is only anecdotal evidence in form of the case reports. And for GEP-NET, currently little data from the control trials. There was GEP-NET was part of the various advanced solid tumors, part of the KEYNOTE-021 studies, and overall response rate for advanced PD-L1 positive NETs were 12% and 6% for pancreatic. No complete response have been achieved. And then again, case studies, Merkel, I will say later on. On the ENET 2017, the last presentation, at the end of the conference was that there are only anecdotal information regarding immunotherapy for NET, and there are no clinical studies. So now you can see that clinical studies also started also for the neuroendocrine tumors, not only for Merkel cell carcinoma, but also for unresectable metastatic well-differentiated NET, but also for the high-grade NET or neuroendocrine carcinomas. So as you can see, there are some studies, phase 2, but of course preliminary results, nothing was published yet because it is really ongoing only. Regarding Merkel cell, I'm sorry, but they put the two presentations to one, so that's why I'm so fast. I'm maybe talking so fast. So Merkel cell carcinoma, special neuroendocrine carcinoma of the skin. The immune profile is completely different based if there is positivity of Merkel cell polyomavirus, yes or no. So there are completely two different groups of the Merkel cell carcinoma, as you can see here, because for Merkel cell polyomavirus positive, the main characteristics from the side of the immunotherapy is mutation load is low, microsatellite instability is stable, infiltration is high, expression is high, expression of major histopathologic complex class 1 is low, usually diploid tumors, and prognosis is better compared with Merkel cell polyomavirus negative group of the Merkel. Why or what is the ratio to use immunotherapy for Merkel cell carcinoma? For virus positive tumors, there is expression of the viral antigens which could be recognized by an immune system. For virus negative, there is high mutation burden. Second point, that immunologically in many cases, there was recognized immunologically mediated spontaneous regression. In 40 patients with advanced 3B Merkel cell carcinoma, there was unknown primary, because primary tumor was most probably effectively immunologically eliminated. So this is the reasons and ratio for use of thinking about the immunotherapy for this kind of the tumor. There were several studies, controlled randomized studies, or randomized, it was single arm studies, but controlled studies with nivolumab, pembrolizumab, avelumab. And I will be talking, because I do not have a time, only about the avelumab, because based on this registration study, Javelin Merck 200, there was 2 arms, arm B used for refractory patients, or arm B as a chemotherapy naive patients, so in the first line. And based on this clinical trial, there was FDA approval in US in March 2017, in the EMA in Europe in September 2017 for metastatic Merkel cell carcinoma in first and second line for patients older than 12 years. So even for part of our population, because I'm pediatrician. So here, the last 3 slides. First is the results of the arm A, means in pre-treated patients with metastatic Merkel cell carcinoma. You can see the objective response rate was about 31% or 32% in 6 months, and after 1 year more than 33% complete response. Again, quite a good number of patients, heavily pre-treated metastatic patients. Because, for instance, in Czech Republic, the median survival in metastatic Merkel cell carcinoma is about a couple of months. So that's why this is very nice numbers. Response more than 6 months, you can see here 30 patients, more than 1 year, 74 patients. Here you can see the overall survival curve in metastatic, and here clinical activity after 1 year after the therapy. And this is the arm B, so in the first line, in the chemotherapy naive patients, again you can see objective response after 6 months in more than 71% of the patients. So again, stabilization and partial response, complete response nearly in 30 patients. So if you are using the anti-PD-L1 or anti-PD-1 avelumab in the first line, you have better response than in pre-treated patients. So take-home message regarding this issue: there is only limited numbers of studies focused on the immunotherapy used for neuroendocrine tumors. Very limited information regarding tumor microenvironment. As I said, mutational burden is generally low. Microenvironment is still based on the grade, on the localization of the tumor, and the role and usefulness is still open. Of course, is not indicated for well differentiated localized tumors or tumors who are managed with standard treatment. But if you have recurrent patients and you do not have the therapy of upper priority, I think that this is the patient who can receive the immunotherapy. Probably you can see the effect of the immunotherapy. Again, the challenge is heterogeneity of the neuroendocrine tumors and identification of the predictors and biomarkers. Because, as I said, even if you have generally, when we conclude that they have immunosuppressive microenvironment and less positivity of expression of PD-L1, theoretically there is no reason to use the immunotherapy. But from our own experience with pediatric types of the tumors, not NETs, we have the same problem, and we have effectivity, and for highly recurrent, highly risky tumors, 5 years survival more than 60%. So still we discussed about the predictive biomarkers, but they are not working for 100%, and doesn't mean there is a lot of the things we still don't know. And rigorous data regarding using immunotherapy are still missing. And as a part of the metastatic Merkel cell carcinoma, there is the only neuroendocrine tumor where the immunotherapy is now part of the first line and second line therapy. So it is the only neuroendocrine tumor when the immunotherapy is established and prone. Thank you.
Thank you, Vera, for this deep insight in this hot topic. And I think that's nothing to add at this moment.
No, Professor.
Yes.
A short question. Is there any place for adjuvant, in an adjuvant setting for Merkel cell carcinoma patients?
It's not evidence-based.
No.
No classic chemotherapy and no...
Classic chemotherapy is usually, when you are using the classic chemotherapy for Merkel, you can see the response rate, but within a couple of weeks there is progression of the tumor, so response is only for a couple of weeks. So now it is not working and immunotherapy is recommended as a first or second line treatment.
It's not evidence-based.
It's not, no. As an adjuvant, no. In a guidelines for the Merkel cell carcinoma as an adjuvant, no, that you do not have the macroscopic disease.
Thank you, and let's move to genetic syndromes associated with trends. I would like to ask Dr. Patoc from Budapest Semmelweis University Institute of Laboratory Medicine.
Thank you very much, dear Chair, dear colleagues. I would like first to thank the organizers, the IPSEM, for giving the possibility for me to talk about one of my favorite topics, the genetics of neuroendocrine tumors. And of course, I congratulate for this very comprehensive program. I learned a lot. So my topic, I have three main topics. First two I will skip very fast, but in the third section, through some cases, I would like to present how is the work in our department and how can we figure out the real situation in some very interesting cases. So the genetically determined neuroendocrine tumors, very similar to the sporadic counterparts. It can be developed from all over the hormonal system, and the same question occurs. These are hormone-producing tumors or hormonally silent tumors, benign or malignant, the phenotype. These are the main questions which the clinician frequently asks us. So the clinical presentation is very similar to the sporadic tumors. If there is a hormone oversecretion, we have very typical tumors. But I have to mention here the first feature. These tumors, even the genetically determined neuroendocrine tumors, are very rare, ultra rare. In some cases, there is no real meaning of any genetic test for some cases. Of course, for diagnosis and for further treatment, we have specific challenges, like very frequent occurs. The diagnosis is very late, sometimes more than 10 years to have the final diagnosis for a rare neuroendocrine tumors, regarding the genetics as well. The highly variable genotype-phenotype association, I will show some data about this. And in Hungary, at least, we have a very highly underdiagnosed cases. The diagnosis needs specialized endocrine centers, endocrine units, including laboratory, molecular genetics laboratory, and of course, it's a bilateral or multilateral interaction between geneticists, clinicians, oncologists, and radiologists. Of course, in some cases, we need functional imaging procedures, we need invasive hormonal analysis, and of course, targeted genetic testing, and not genetic profiling or gene panel or exome sequencing for these tumors. Of course, the genetics may affect the prognosis and treatment. I will show some details about the prognosis, how the genetics involved in this feature. And it's a very important message. If we find a patient with genetically determined syndrome, it's not only the situation for the patient itself, but also the family members are involved, so they should be aware about the situation, and genetic counseling is the procedure where we can tell and explain for the family members as well the situation. It means sometimes we have a lifelong consequences, so the patient should be aware about this, and also the long-term health-related direct and indirect costs can be very enormous. And sometimes we have a very interesting discussion with patients about the benefit of screening of presymptomatic patients regarding in MEN1. I will show some data about that. Okay, so similarly to the sporadic tumors, even the genetically determined tumors can be hormone producing. GH producing tumors are frequently associated with familiar isolated pituitary adenoma syndrome, which is caused by the AIP gene. I won't discuss about that. In thyroid, we have the medullary thyroid cancer, which is the prototype of the neuroendocrine tumor, which is genetically determined. In MEN2 syndrome, I will discuss about that. In parathyroid, similarly, we have MEN1, MEN2. From adrenal, I would like to highlight the pheochromocytoma, which is one of the most important genetically determined tumor syndrome. To date, we have more than 15 genes involved in the genetic background of pheochromocytoma. Regarding the, as you saw in the previous presentations, in real neuroendocrine tumors affecting the gastrointestinal pancreatic tract, we have very few genetic syndromes. Of course, it can be part for MEN1. I will show the data, but regarding the lung, it's no real tumor syndrome. For Merkel cell tumor and neuronal tumors are also very, very rare to associate, and even as you saw before, even in the somatic mutation status are very limited, and only few mutations can be detected in these tumors. From laboratory aspects, we have the similar possibilities for screening and for diagnosis. Chromogranin A, we had a discussion about that, also 5-hydroxyindoleacetic acid. It's important for diagnosis of genetically determined tumors, and it's important for screening in genetically affected family members. So pituitary I will skip, or I will start here. I grouped these syndromes in two main categories. The classics, I call classics because we have a lot of data, and in databases we have a very good overview about the manifestations associating in MEN1, MEN2 for Hippel-Lindau disease and neurofibromatosis type 1. There is a clear genotype-phenotype associations which can be used in everyday clinical practice. Less known means that, of course, in hereditary pheochromocytoma, if associates with MEN2 or VHL, the situation is much clearer than if associates with newly identified genes. For sclerosis tuberosa, Carney complex, Cowden disease, and Li-Fraumeni syndrome, the clinical information and the clinical message regarding genetics is limited. Who knows what is the Cowden disease? In this room. Cowden disease. What is the gene behind the Cowden disease? It's a PTEN. It's mutated in breast cancer mainly, okay? So, but the PTEN mutation occurs in germline level. We have this syndrome called Cowden disease. We have in Hungary 2 or 3 cases diagnosed yet. But in the US, it's very common because there is a specific program for screening for this type of syndrome. Okay, going to MEN1. You know that is a 3P syndrome. It's very easy to memorize. Hyperparathyroidism, pituitary tumors, and neuroendocrine tumors of pancreas. And I would like to draw your attention to the minor manifestation. If you have a patient with hyperpara and lipoma or specific skin tumors like angiofibroma, collagenoma, it's very highly the chance that the patient has an MEN1 syndrome. Of course, if the patient is young and the tumors occur at multiple sites or bilateral, the chance is more to have a genetic syndrome. All these tumor syndromes are autosomal dominantly inherited, which means that the first-degree relatives have the chance 50% for inheritance of the mutation. In MEN1, no genotype-phenotype associations can be found, which means that even in the same family, the family members can present with different phenotype. We have members, older members, which had only hyperpara, but younger children developed first GAPNET tumors or pituitary tumors. So it's really challenging to find the clue what's ongoing in MEN1. Why is important the genetic testing in MEN1? Because we have a very good screening program. Of course, it's hard to explain for the family members. I have to mention again, family members means family has a mutation, and the presymptomatic individual was screened for mutation first, and we found the mutation. Then this clinical procedures where it's our aim to diagnose the tumor as early as possible for prevention, for minimal invasive surgeries. So therefore, if in a mutation carrier, the timing of screening procedures are listed here. Of course, in young individuals, in children, the radiology imaging techniques are less used. Here is our data regarding the MEN1. In Hungary, we started MEN1 screening in 1998, more or less, 2000 maybe, but we have at least 20 years experience in MEN1. Despite of this effort, we identified 27 individuals. These are the index patients. It's not the family members, just the families. And in these 77 patients, the clinical diagnosis was MEN1, which means that in those patients, at least 2 of the main manifestations occurred in the same patient. And despite we identified only this low number of patients, and I would like to draw your attention to the GAPNet tumors, because GAPNet tumors presenting at multiple sites or in younger individuals had the most positive predictive value to have a MEN1 syndrome. So it's very important association. Here is the data presenting in this format, and you see here the GAPNet was the most important association which predicted our cases to have a MEN1 germline mutation. Of course, in previous talk it was talking about the somatic mutations. There are interesting findings. Even our group studied microRNAs and somatic mutations of MEN1 gene in hyperparathyroidism, in sporadic adenomas as well. And I just want to show one important finding using menin immunohistochemistry. The menin is the protein encoded by the MEN1 gene, and if you find a staining, lack of menin staining, you can have germline MEN mutation, which is the case for MEN1 syndrome, and also at least 1/3 of the sporadic primary hyperparathyroidism shows similar immunostaining. And in these tumors, somatic mutation or microRNAs targeting MEN1 gene could be responsible for the tumor development. Going to thyroid, I would like to present one case very briefly. It was a young lady presenting with neck swelling, pain in neck and shoulders, fatigue, dysphagia from 1 month. Nothing very characteristic from history. It was normal routine laboratory, as a normal ECG, but the ultrasound showed enlarged thyroid gland with multiple lymph nodes. Fine needle biopsy was performed, followed by histology. It was the clear report, it's MTC. Then the surgery was performed and genetic counseling was ordered by the clinicians. You know, the MTC is a rare cancer. Only 2.5–10% of all thyroid cancers can be medullary carcinoma, originates from C cells. There is a good marker, calcitonin level is a very good marker for monitoring the C cell hyperplasia or MTC. And from genetic aspect, it's very important that 25% of apparently sporadic medullary thyroid cancer can be genetically determined as part of the MEN2 syndrome. MEN2 syndrome, beside MTC, hyperpara and pheochromocytoma, based on clinical manifestation, you have different variants of MEN2. The most severe variant is MEN2B, where the mutation occurs in the RET tyrosine kinase domain. Similarly to MEN1, it's a dominant disorder, but MEN1 is a tumor suppressor gene, while RET is a tyrosine kinase receptor. It's an oncogene when mutated. And here we have very specific genotype-phenotype associations. This is represented here. If you have mutation in exon 10 or 11, more likely you have a phenotype called MEN2A. So the D here is pheochromocytoma. If you have mutation in exon 14, you have familiary medullary thyroid cancer. The chance is very little to have hyperpara or pheochromocytoma. And if you have mutation in exon 16, the more likely phenotype is MEN2B, which is the very serious and the more aggressive form of MEN2. Why? Because the RET receptor is here. In normal function of RET, after dimerization, after ligand binding, the dimerization occurs, the signal is on. In the most common mutation, you have a mutation here, it's extracellular domain mutation. Without ligand occurs the dimerization, and in the tyrosine kinase domain mutation, even without dimerization occurs the signal transduction. So it's very important biological meaning of the signal transduction in RET. And based on the mutation profiles, we have three categories. For MEN2B mutation, you have to tell to the patients, to the families, that to escape the medullary thyroid cancer is the only way to have a prophylactic thyroidectomy. But the timing of prophylactic thyroidectomy is based on the mutation status. You see here the recommendation is 6 months. For the most common mutation, the recommendation for preventive prophylactic thyroidectomy is 5 years of age. And fortunately, we have benign mutations where we can wait until the calcitonin starts to raise. So, going back to our patient, after surgery, serum calcitonin was extremely elevated. The calcineurin embryonic antigen was also very high, and of course, on imaging studies, which multiple metastasis was detected, and we did not find any germline RET mutation. So the clinical diagnosis was sporadic aggressive metastatic MTC. What's next? What's the therapy? Surgery was done. And MTC is relatively unresponsive to conventional doses of irradiation and to chemotherapeutic regimens. So targeted therapy, this case was from 2013, and at that time the vandatinib, the specific RET tyrosine kinase, was already in Europe and in FDA was FDA approved, but in Hungary was not marketed at that time. So we thought with oncologists that the only way to help this young lady to start the vandatinib treatment. Of course, in Hungary it's not easy to start treatment with a drug which is not marketed, so we had to apply for the Ministry of Health. It took very fast. I would say that everything went very well. Why? Because we were able to demonstrate that based on the vandatinib description, you see here, it's a recommendation in patients where no RET mutation was detected or negative, there is a possible lower benefit. Which means when we talk with the ministry, they asked us to prove somehow that this tumor is related to RET, but no germline mutation. So we are a clinical genetics lab. We are not a pathology laboratory. But we had to discuss with the pathology and ask them to give us tumor tissue. Why? Because it was published that the most aggressive RET mutation was found in almost 2/3 of sporadic MTCs. Therefore, of course, it was demonstrated that correlated with poor outcome, with metastatic disease, and it has a prognostic impact. So we went back and asked the pathology department for tumor tissue, and luckily we were able to demonstrate that indeed in this patient there is a somatic RET mutation, and then the Ministry of Health accepted our ask, and the patient was treated with this drug. Here is the result. You see, we started the treatment here. 2 months, we observed a very good response. The calcitonin and the CAA started to decrease. 1 month was very stable disease. So until that, it's 3 months. We are talking about 3 months. Then, in the 4th month, the calcitonin started to raise again. And here, after half a year, the entire history of this patient was half a year we lost, and the patient died, unfortunately. So going to the adrenal medulla for pheochromocytoma, I would like just to briefly show some very important aspect of pheochromocytoma. This is the main message: clinically unrecognized rate of pheochromocytoma. It's very high. can be lethal due to catecholamine overproduction. And it's very important from genetic aspect that almost 1/3, or I would say half of them, are genetically determined. Here is the list of the genes. So we are doing the clinical genetics analysis of all these genes, but the message is very different. If we find a pheochromocytoma associated with VHL, I will show what's the message. But in these new genes, these genes are mainly part of the mitochondria succinate dehydrogenase subunits or MAX fumarate hydratase. Malate dehydrogenase got these enzymes also part of the tricarboxyl acetic cycle, the Krebs cycle. So I would call now pheochromocytoma as a metabolic tumor type. VHL, you know, the VHL, the main manifestation are represented here: retinoangiomatosis, hemangioblastoma, few pancreatic cyst, renal cyst, and renal cell cancer. Based on pheochromocytoma, 2 types of the disease. This is important because we don't know in patients which will be the first manifestation. Typically, the retinoangiomatosis is the first manifestation, but if you have a sporadic pheochromocytoma, you could not eliminate the chance that this is VHL associated tumor. The SDH genes associates exclusively with pheochromocytoma and paraganglioma. However, in recent years, with pituitary tumors and with GIST tumors also, SDH mutation can be detected. Just one case, it was a young boy with one big tumor. After operation, the histology showed pheochromocytoma. 2 years later, next left side, other tumor. And this is very important. If you have a suspicion for a genetically determined tumor, the surgery, the type of surgery should be very should be discussed with the surgeon, because the most easiest way to operate the pheochromocytoma to take off the entire adrenal gland. But if you have a bilateral tumor, if you took out both adrenal glands, you will have a Addisonian crisis or Addisonian disease. So therefore, the minimal invasive surgery should be offered for this kind of patients. So in that boy, at that time, we used the Sanger sequencing and gene-by-gene genetic testing. Now we are using GenePanel, which makes our work much more quicker. And that time we had to think, what is the order, the most convenient and the most clinically accepted order for genetic test. Of course, as you saw already, VHL and the SDHB and D mutation are the most likely behind this case. Now, from 2014, we have a very detailed algorithm from the Endocrine Society for genetic analysis of pheochromocytoma paraganglioma patients, based on the syndromic presentation, based on the localization. And for example, if we have this case, which is extraadrenal, the biochemistry showed it's more noradrenergic. These are the recommendations for genetic screening. We did the genetic analysis and we found the VHL mutation. Why was this important and what can we tell to the clinicians? Here is so the VHL MEN2 neurofibromatosis type 1 is those syndromes where we have very good data collected in international databases. And here you see that the chance to have a second tumor is depending on the mutated genes. And here is the VHL, which means after 15 years from the first tumor, it's the patient 40 or 45% of pages will have another second paraganglia tumor. About the gene-specific survival, you see here the NF1 and the SDHB genes are those genes which associate with more malignant disease. Why? Here is a typical radionucleotide imaging of a patient with SDHB mutation. In our experience, now we have more than 6 SDH mutated patients. We have around 10, and half of them already died before age of 40, despite of all efforts. So there is no real treatment for SDHB mutated pheochromocytomas. But from genetic point of view, what can we tell to the patient and to the clinicians? If we find a mutation, genetic counseling is mandatory for explaining what is the mutation, what does it mean, and we have to offer the mutation screening in first-degree relatives. If we find the mutation positive presymptomatic carriers, we go back and we perform and order the periodical screening procedures for FAO, includes the catecholamine metabolites analysis, imaging techniques, and in mutation-negative cases, it's very good, nothing to do with those individuals. I will skip this because I think my time is over now. Just a summary slide, which is here. So these genetically determined endocrine tumors are rare, but we can identify, we can diagnose these tumors. Of course, the diagnosis, treatment, follow-up, and patient care are challenging. Multidisciplinary approach is needed, and even it was mentioned several times today that the neuroendocrine tumors itself is intra-individual and everything is different. This is true for genetically determined forms as well. And the diagnostic and therapeutic possibilities, I think, in small countries can be available only in highly specialized centers, and I would say in Hungary, one or two centers, I think is more than enough to have all infrastructure to do this kind of work. And sometimes, despite of all our efforts, these tumors may show a very aggressive behavior, and we can lose these patients as well. So thank you for your attention.
Thank you very much for this wonderful lecture. Are there any questions?
Yeah.
Yes.
Thank you. It's an excellent presentation. I have one question and one comment. Sometimes the Mother Nature is really joking with us because we have case of 17-year-old boy, and he was seen by the doctor because of the tinnitus.
Okay.
They do whatever, and only they measured also BP. So they found that there is high hypertension, and that's why they asked for the further treatment to exclude what kind of hypertension it is. And they found the solid mass, tumor mass in the right kidney and huge mass in the para-aortal region. Okay. So he was sent to our side that kidney tumor with lymph node mets. So we did a surgery, and the pathology was there was paraganglioma and SDHB negative renal cell carcinoma. So simple tinnitus leads to diagnosis of the two tumors. Of course, we sent him for the genetic, and it was SDHB mutation. So we asked also for the family, and his brother is positive as well. My question is, if you have a cancer predisposition syndrome, not only the patients with the tumor, but also you have confirmed that family members are positive, who will follow these patients?
It's a very good question. In Hungary, we do. As a genetic counselor, we try to organize everything. Of course, if we need an endocrinologist, we ask the endocrine department for specific, and if we need imaging studies, we ask the radiology department. And this is the case what is the most complicated, because we need very various discipline for accurate treatment. But in Hungary, the genetic counselors should, I think, they are medicals, so it's in Europe, it's even in the US, it's a very different education background for genetic counselors. But in Hungary, we have medical doctors as a profession to be a geneticist, and we try to follow. We try to organize. This is an organization.
So you as a geneticist organize?
Yes, mainly yes.
Because here in the Czech Republic there was recommendation from the genetics for the medical oncologist that
but
these patients
in some
will be
cases
followed
you
by
don't.
medical oncologists.
Okay, for SDHB mutation, yes, because it's a malignant phenotype. In general, I think no. No, because in most these tumors are benign tumors. Even it's no oncology duty. sometimes I think more likely you have endocrine problems, and endocrinologist should be one involved. Yeah. Of course, if you have a malignant disease, and you need oncologist for sure for treatment, but in presymptomatic individuals, just for screening, we try to organize the geneticist, and we ask for specific technique the special centers. Yeah.
Thank you very much
You're
indeed. And the next topic is management of insulinomas, and I would like to ask Konekinova, the head of Department of Internal Medicine, Comenius University at Faculty of Medicine in Bratislava.
Good evening, ladies and gentlemen. Aim of my lecture this evening is management of insulinomas. All we know that the GAP NETs are classified for intestinal neuroendocrine tumors and for pancreatic endocrine tumors, and insulinomas belong to functional PNETs. Insulinoma are more often from the functional PNETs, with incidence from 1 to 2 new cases in 1,000 inhabitants in 1 year. And 5 to 10% of insulinomas have malignancy behavior. A clinical manifestation of insulinoma is very, we have many signs. Most often is hypoglycemia. Patients could have sweating, syncopes, hunger, palpitation, weakness, paresthesias, anxiety, or blurred vision. But really, typical is combination of hypoglycemia, confusion, sweating, and weight gain. Patients with insulinomas characteristically develop symptoms while fasting or during exercise. However, some of these patients, up to 18%, develop symptoms postprandially, and this may be the only one symptoms. In one single institutional study, this patient complained of postprandial symptoms, and 21% had previously been affected by diabetes type 2 or by impaired glucose tolerance. These data support previous findings that a subset of patients with insulinomas may be diagnosed on the basis of an altered insulin secretory pattern during an oral glucose tolerance test, inducing hypoglycemia rather than the classical 72 hours fasting test. For diagnostic criteria, we are using Whipple triad with hypoglycemia, symptoms and signs of neuroglycopenia, which resolving after administration of glucose. So biochemical diagnosis of insulinoma is based on concentration glucose less than 3 millimoles, insulin more than 18 picomoles, C-peptide more than 0.6 nanograms, proinsulin higher than 5 picomoles, and beta-hydroxybutyrate less than 2.7. But study of Buffer and colleagues demonstrated that some patients with insulinomas can have plasma beta-hydroxybutyrate levels higher than 2.7, especially if these patients have previously undergone partial pancreatectomy or are being evaluated for a recurrence of disease. In contrast to the other PNETs, a recent study reported that evaluating serum chromogranin A levels is frequently not helpful for diagnosis patients with insulinoma. An elevated chromogranin A value has only 73% specificity compared to 92% if non-insulinoma PNETs patients. In a small percentage of patients with insulinoma, all conventional imaging studies, including endoscopic ultrasound, are negative. PET-CT scan with gallium-labeled somatostatin analogs is also positive only in 25 to 30% of all patients with insulinoma, and therefore is not helpful for us. 2 other modalities continues to show promising results in these patients and should be considered. It's receptor scintigraphy with radio-labeled glucagon-like peptide 1, receptor analogs, which is sensitive, method because insulinomas frequently overexpress these receptors. However, it's not available in Central Europe. Functional localization after selective intraarterial injection of calcium with hepatic venous insulin gradients has proven to be a highly sensitive method to localize insulinomas and is positive in 90 to 100% of all cases. And therefore, it should be considered in patients where other imaging tests are negative. Problem is with patients with MEN1 type syndrome, because in these patients with insulinoma, many of patients has multiple PNETs, and many of these PNETs are non-functional, and therefore singling out of the insulinoma from these non-functional PNETs can be extremely difficult, and in this patient is also indicated intraarterial calcium testing. On this picture, you can see recommendation how we can make a diagnosis of insulinoma. When we have suspicion for insulinoma, in clinical picture, patients has Whipple trialed, 72 hours fasting test could be considered. If it's negative, we have to send patient to prolonged oral glucose tolerant test or mixed meal test. If patient has hypoglycemia, then we have to do differential diagnosis about hypoglycemia. If it's no hypoglycemia result of this test, we have to follow up the patient. If the test is positive, then we try to localize the tumor. If we find the tumor with unresectable liver mets, then we treat the metabolic disease. If we have no visible lesion, then we performed endoscopic ultrasound and another methods, and we try to find the tumors. If it's visible lesion, then we could send patients to surgical departments to make a surgical procedure. What with the surgical treatment with insulinomas? Many recent studies demonstrate that both in adults and in children, the surgical exploration results in a high cure rate, about 89 to 100%. In most cases, and in small tumors, enucleation of the insulinoma is possible, but in some patients it's not so, and also a laparoscopic approach is generally recommended in patients with sporadic disease when we have localization of the tumor and the tumor is less than 1 centimeter. Surgery remains the preferred treatment whenever is possible, but prior to the surgery, recurrent cases and patients with malignant insulinomas need also medical treatment. We have to use diazoxide, frequent small meals, somatostatin analogs, but somatostatin analogs are not good in patients with malignant insulinoma because they worsen the hypoglycemia due to suppression of contrarregulatory hormones. Then we can use mTOR inhibitors, everolimus, which demonstrated to be effective in controlling hypoglycemia in an increasing number of reports. And also sunitinib has been effective in few patients. In patients with a localized insulinoma who are not thought to be candidates for surgery, the use of ablative therapy, either endoscopically or percutaneously with radiological guidance, has been reported to be successful, but we need also further data. Endoscopic ultrasound-guided ablation using an ethanol injection or CT-guided radiofrequency ablation has also been reported to be successful in treated in patients with insulinomas. We heard in previous lecture also about selective embolization and about peptide receptor targeted radiotherapy. Promising data have involved that PRRT using yttrium or lutetium in the treatment of PNETs with distant metastasis are very helpful for our patient. Our colleague tell about PRRT, so I will skip this. Only what I can once more tell to you that really NETO1 study indicated that the estimated risk of death was 60% lower in patients who was treated with lutetium than in the control group. For treatment with PRRT, we need following requirements: histopathologically proven NET, high somatostatin receptor scintigraphy, grade 1 or 2 of tumor, and really good function of liver and bone marrow. These are another parameters which we have to have in normal range when we want to send the patients to the PRRT treatment. After this treatment, also patients should be monitored each 2 weeks, kidneys parameters and blood count, and conventional image CT or MRI every 3 to 9 months in patients with grade 1 and grade 2 tumors. If positive somatin receptor scintigraphy should be reported only after 2 years or earlier if the progression is suspected. I would like to show you one of our patients with insulinoma. It was 56 years old male with history of hypoglycemia from July 2017. He has visual disturbances, palpitation, weight gain, sweating, and multiple liver mets were found and tumor in head of pancreas. All laboratory results are typical for diagnosis of insulinoma, so combination of lab levels of glucose, high levels of insulin and C-peptide, and we measure all other hormones and contrarregulatory hormones to distinguish if patients could have, for example, Men's syndrome. PET-CT show hypermetabolic tumor in cauda of pancreatitis with multiple liver mets, and therefore diagnosis of malignant insulinoma was established. This is Octreos scan also with primary origin in the pancreas and multiple liver mets. Due to severe hypoglycemia, we started treatment with prednisone and diazoxide, also octreotide 3 times per day. And at the end of the November, 1 year before, distal pancreatectomy with splenectomy was performed. Histologically, it was KI index about 10%, positive angioinvasion, and therefore the histology diagnosis was NET pancreas grade 2. In January 2018, we started treatment with somatostatin autogel, but unfortunately, the hypoglycemia was worsened. Patient has really severe problems, and therefore we stopped this treatment. And in February this year, we started with everolimus 10 milligrams and continue with prednisone 15 milligrams per day. According to description of the Octreos scan from November, we sent patient for PRRT treatment. 3 cycles with lutetium were recommended. This 3 cycles was in March, May, and July this year. Between this treatment, patient was treated with everolimus 10 milligrams per day. He has no significant hypoglycemia yet. You can see the levels of glucose normal range, levels of insulin and C-peptide also in normal range, and SPECT-CT, what we do 3 months after PRRT therapy, showed slightly decreased of liver mets. So this is the typical management of patient with malignant insulinoma, in which the recommendation for somatostatin analogs, which we are using every day in PNETs patients, is not very helpful, but on the other hand, worsening all the situation. So in these patients, we could have combination of all treatment modalities, also with PRRT. We don't have possibility to make PRRT in our republic, but like Czech colleagues, we send patients abroad. Thank you for your attention.
Thank you very much. Questions, please? There are no questions. Let's move to the last lecture, last not least. lung neuroendocrine tumors, and I welcome Dr. Galfi from Terekbali, and I'm afraid that I'm not able to pronounce the department. Is it Tüde-György-Intézet?
I'm sorry, Pulmonology Department of Pest County.
Thank you for explanation.
Thank you very much. Dear Chairman, dear colleagues, first of all, I would like to thank to the Ibsen company to invite me for this meeting. My topic is lung net. 25% of the neuroendocrine tumors came from the lung. The lung net, its incidence is rate 0.5 of all malignant tumors, 1–2% of the primary pulmonary tumors. Incidence is 2.3–2.8 cases per 100,000 persons. There are in Hungary yearly around 200 cases. The most common occurrence is in the middle age, between 40 to 60 years. There are many types of typic carcinoid. It's very common between the younger age, less than 50 years. It's yearly, and this is better prognosis. And the atypic carcinoid, the median years is 55 years. There are worse prognosis than the typic carcinoid. Typic and atypic ratio is 8:1. Smoking is most common among the atypic carcinoid patient, and the most common primary lung cancer in the children and the young adults. 95% is sporadic and 5% related to the MEN1 syndrome. This curve was common. The lung net incidence is increasing nowadays, and almost 45%, 43% of the lung net is asymptomatic. Every year in Hungary we are doing and we are collecting the data of the lung tumors, and you can see the last year statistic, lung tumor statistic, not only the neuroendocrine but all of them. And you can see that the neuroendocrine, the small cell lung cancer, this is the high neuroendocrine tumor, it's 15% in the Hungary. And the other high grade is a large cell in 1–2% in the last couple of years. And the carcinoid tumor is pretty stable, around 2% in the last couple of years in Hungary. The classification of lung neuroendocrine tumors, we know very well, the well-differentiated bronchus net, this is a typic carcinoid, is a well-differentiation, and the atypic carcinoid is a poorly differentiated tumor, worse prognosis than the typic one, of course. And the high-grade tumor is a small cell neuroendocrine carcinoma and a large cell neuroendocrine carcinoma. Terminology of the neuroendocrine tumor, of course, the low grade, intermediate grade, and high grade. It was a nice presentation with, from Katalin Borka from Hungary. I think I do not want to repeat it. The classification is also very interesting because three main things that we can follow in the case of typic, atypic, and high-grade lung neuroendocrine tumors: the mitosis index, the Ki-67, and the necrosis also. And it was also discussed with Katalin Borka, I think. We know from the publication that lung net, there are worse prognosis than the GI net. There are several publications about that. And if we talk about the 5 years and the 10 years survival, we can see that in the typic carcinoid, there are pretty nice 5 and 10 years survival, more than 87%. But in the atypic carcinoid, it's much more lower, around 45% of the 5 years survival and 35% of the 10 years survival. And in the high-grade tumor, there are much more worse 5 and 10 year survival, unfortunately. There are special prognostic factors. We know histologic type, age, sex, TNM stage, and of course the tumor size that is larger than 3.5 centimeters. We can discuss the same thing that we saw the previous 2 slides with the Kaplan-Meier curves. The better survival in the case of typic carcinoid, atypic in the intermediate, and of course the high grade is a pretty small survivor. It's not easy to find for us, for pulmonologists, to find a final diagnosis. Why? Because the lung net, in the case of peripheral localization, it's typical in the atypic carcinoid, and from the we can find the histology samples from the peripheria during the transbronchial biopsy or the core biopsy, because we need to find for the histology, because the histology it's a for sure. And atypic, because this is a peripheral localization, mainly that is asymptomatic. Typic carcinoid, there are mainly in the central localization and cause the obstructive symptoms. It's asymptomatic. Of course, much more easier to find the symptoms from that. 60% of patients are symptomatic. The most frequent symptoms is the cough, hemoptyem, pneumonia, chest pain, dyspnea, and the carcinoid syndrome. The biochemical marker, we also discussed, the chromogranin A level, 60% positive from small cell lung cancer, and 75% positive for other lung net. We can think about also the causes of false positive chromogranin A results. NSL level for high malignant bronchial net is important, and other markers depend on the hormone symptoms, urine 5, serum and urine cortisol, and ACTH. There are special symptom complex in the lung net, carcinoid syndrome to 5%, mainly in the case with the lymphometastasis are the most common, and ectopic ACTH syndrome 1-3%, mostly common with Cushing syndrome, and 40% with lung net. From the NS guideline, we can follow and we can find how can we do the final diagnosis. In the typic and atypic carcinoid, it's very important the CT is the first step, of course. And after the CT, chest and abdominal CT, of course, and spine MRI is very important thing because very frequent the bone metastasis. But the final step is the bronchoscopy to find the biopsy samples. If we couldn't find with the simple bronchoscopy, we can do the transbronchial biopsy, as I mentioned, or we can use the EBUS to find the diagnosis. Because very important to find the way how can we find the histology samples, because cytopathology may not differentiate typic from atypic carcinoid, and that's very important to find the pulmonologist the histology sample, not enough the cytology samples. And of course, we use SR Octao and the gallium PET CT and the FDG PET CT, mainly for the high-grade histopathology tumor, large cell and small cell. And Octao we use as atypic and typic, in the case of atypic and typic carcinoid. Put together the diagnostic results. In the case of low-grade typic carcinoid, CT, first step, and the second recommendation, the gallium PET CT. And in the case of typic carcinoid, it's very common, the chromogranin. In the case of atypic carcinoid, after the CT, also recommended the gallium PET CT, and very common the chromogranin and the NSE marker elevation. And could be used also the FDG PET CT. In the case of high tumor, high-grade tumor, large cell and small cell carcinoma, recommended the FDG PET CT. And dose, among the dose ring, it's elevated the NSE and not the chromogranin. We also mentioned that pulmonary NET patients at the diagnosis, it's very common, the bone metastasis and the liver metastasis. Diagnostic strategy of the typic carcinoid and the atypic carcinoid. The first thing to find the tumor histopathology. We can find either way, we can find a histology sample. We can find the correct typic and atypic carcinoid. Tumor stage is very important because after the correct staging, we can use as an oncoteam, and during the oncoteam, to use the decision, is a resectable tumor or unresectable tumor. Majority of the typic carcinoid is a resectable tumor, and the patient is very well after the operation. And in the case of atypic carcinoid, the minority only the resectable tumor. Functionality, we can find the hormone-related symptoms, and somatostatin receptor functional expression we can show and follow. I mentioned the DOTA PET-CT and the FDG PET-CT. Gallium DOTA ultrasound PET imaging more sensitive than the Octreo scan in the typic carcinoid than the atypic carcinoid. And as I mentioned, the FDG PET more sensitive in the high mitotic index patient, in the high-grade patient, in the small cell lung cancer and the large cell lung cancer patient. Also, you can see these results, FDG PET and the gallium DOTA in the low-grade tumor, recommended the gallium DOTA, and the high-grade tumor recommended the FDG PET because more sensitive. We have several therapeutic options. Somatostatin analogs could be also a choice, but only in the case of lung cancer, lung neuroendocrine tumor for the symptom control. Few data for tumor control. We are waiting for the SPINET result, lung-crowded versus placebo. Targeted therapy, everolimus, Radiant, based on the Radiant 2 and Radiant 4 results and the LUNA results. Chemotherapy, temozolide-based therapy, and platinum-based therapy is recommended. And of course, also recommended the peptide receptor radioactive therapy, the PRT, and the new clinical results. We have pretty nice results with the immunotherapy, as the previous lecturers mentioned. Last year was published a pretty nice paper, the European Journal of Lung Cancer, of the anti-tumoral activity of the SS analogs in metastatic lung carcinoid. You can see the pretty nice overall survival, but in the lung net, the SSI is not registered yet for the SN anti-proliferative cases, only the symptoms control. We are validating the SPINET results, and we can wait another almost 3 years, unfortunately, to find the end of the results, because from these results, maybe we can use the SSRI as an anti-proliferative agent, but it's not yet the final results, only we are in the middle of the clinical trials. Based on the Radiant 4 paper and trial was registered, the everolimus, in the therapeutic choice in the lung neuroendocrine tumor. The primary endpoint was the progressive-free survival, and the secondary was the other one. We can know very well the results. As we can see, the progressive-free survival was 11 months with the everolimus, in the lung everolimus, and was only less than 4 months in case of placebo. These curves you can show in the lung net subgroups. And the subgroup analysis we can see in the lung carcinoid, the everolimus was much more very well than the placebo arm. the previous presentation was also mentioned the LUNA clinical trials. This is a phase 2 clinical trials. This is ongoing trials. This compared the pasireotide, everolimus, and the combination of pasireotide and everolimus. We can see, and we are waiting very well these results. Maybe this could be other choice to treat the lung neuroendocrine tumors. And also mentioned the chemotherapy as a therapeutic choice. The old thing, this is a platinum-based chemotherapy, platinum etoposide and carboplatin paclitaxel, as a previous paper published. And also there are pretty nice results in the case of bronchialnet, in the temozolomide combination. In Hungary it's off-label yet. We can find, but we can ask the off-label indication. And there are pretty nice results also the oxaliplatin-based chemotherapy in well-differentiated lung neuroendocrine tumors. And we can have a pretty nice presentation with the PRT with advanced lung carcinoid. You can see these pretty nice results also, and the disease control with the PRT in the case of metastatic lung neuroendocrine tumors. And the future, it's hopefully, I think, as a lung cancer and the melanoma and the other cancer, also the immunotherapy. In the 2 months ago, the World Lung Cancer Conference was organized in Toronto. In the case of small cell lung cancer, it's a poor prognosis, as you can know, was a nice result, the Improver 133, platinum etoposide plus atezolizumab was showed a very nice overall survival in the case of first-line small cell lung cancer patient. It's the first, it will be the first registered immunotherapy, it will be not yet, in the case of small cell lung cancer in the high-grade tumors. You can see the pretty nice results with the immunotherapy in this paper. And we can see the INETS guideline 2016, this is a fresh one, put together this our knowledge in the hormone-related symptoms, the SSR, locoregional therapy, interferon and PRT is suggested. In the lung carcinoid, in the case of typic carcinoid, of course, surgery, if it's possible. And as I mentioned, the majority of the typic carcinoid is an operable case, and we can only follow as an oncologist the patient. And the observation, of course, SSR, imaging-guided local therapy, and of course, it's a progressive. We can follow the atypic carcinoid therapy. In the case of atypic carcinoid, SSR, interferon, and everolimus also registered as and the chemotherapy, as I mentioned, temozolide and the platinum-based chemotherapy and the PRT. And we have several guidelines, NCCI guideline in the case of NET, NCCI in the case of small cell lung cancer, ESTS, and the NS guideline. I would like to tell that in the case of small cell lung cancer, we can follow the small cell lung cancer therapy. I mean, the first choice right now is the platinum etoposide therapy, and maybe in the future will be, as I mentioned, platinum etoposide plus immunotherapy. And in the large cell high-grade tumors also we can follow those things. In the case of INETS guideline, octreotide, langreotide, or everolimus is the first subjective choice, of course. And in the worst prognosis, we can use a platinum-based chemotherapy and the temozolide also. Summary, I can think, maybe I can summarize our knowledges. The first very important thing to find the histology samples, because without histology samples we cannot know the correct diagnosis. That's a typic or atypic or small cell or large cell. It's impossible for the cytology. We can find, as a pulmonologist, to find the histology samples. We can follow the guidelines, of course. In the case of atypic typic carcinoid, it's a very good INETS guideline. and we can use our knowledges, we can use the SSR as we could, only and symptoms control, yet unfortunately, maybe a couple of years later, we can use as an antiproliferative effect than the other tumors. And we are evaluating the SPINET results and the LUNA results also. PRT is also a very good choice in the metastatic lung neuroendocrine tumor. And we have very nice results, the immunotherapy, but unfortunately not registered yet, maybe in the future. Thank you very much for your attention.
Thanks a lot. It was a nice dot of our section. And is there any question? Okay, everybody's tired, I think. I would like to express my thanks to the organizers of this session, to Ipsen Company, and I would like to thank to all speakers. We enjoyed the lectures very much, and I would like to thank to the whole auditorium, which was able to absorb so many information in such a short time. So thank you very much once again, and enjoy the evening and have a rest. Thank you.
I would like to thank you so much that you are staying here. And I have just only one organizational thing. The bus will leave at 6:30, so you've got half an hour for the refresh. It's not necessary to be there 6:15. It's just a meeting for the RCC or for the quickest from you. 6:30, the buses will leaving, or 6:35. My colleagues will be there, also the guides. And see you in the restaurant. I will be there. And I would like to ask you just only one thing. If you can give back the voting devices, it's possible to give it to my colleagues, the registration over here. Thank you so much. Easiest. Leave it at the table. Yes, yes, yes. Thank you. Thank you so much. Thank you. Thank you so much. Thank you.
Bude také